in various surgical treatment options for vitiligo, especially melanocyte transplant for vitiligo. You all know vitiligo or leucoderma is an autoimmune chronic depigmenting skin disorder having chalky white macular skin lesions. It affects 0.5 to 2% of worldwide population, with a higher prevalence noted in females and those of darker skin during the first 2 decades of life, and then an even prevalence across ethnicity and gender in latter decades. Though vitiligo is a benign condition, it has significant psychological impact on quality of life, and many patients experience low self-esteem due to cultural factors and stigmatization. So what are the vitiligo medical treatment options? Many medical treatment options are available as a first line of treatment for active and progressive vitiligo, like UV therapy, laser therapy, topical steroids, and topical immunomodulators. What are the surgical treatment options? In recalcitrant stable vitiligo, surgical methods have found to be effective and faster, especially those patients who are in the marriage age group. They want earlier and effective treatment, faster treatment in that age group. Vitiligo surgical treatment history. The first surgical treatment to be reported in treating vitiligo is the split thickness skin graft, which was done in 1947. Since then, there are many advances in the surgical approach, which we'll see. What is the aim of vitiligo surgical treatment? The aim of surgical treatment in vitiligo is to transfer melanocytes from unaffected normal donor skin to hypopigmented recipient areas. What are the various treatment options? There are main 3 plastic surgical treatment options which we have explored in our clinical practice at Bembde Hospital since last 23 years. Our most preferred choice is autologous non-cultured melanocyte transfer since last 10 to 12 years. Previously, we used to use split thickness epidermal skin grafting for vitiligo. And also, we sometimes use complete excision of vitiligo patch and advancement flap for closure in very few selected cases for certain anatomical sites, which we'll see in the presentation. What are the right candidates for melanocyte transplantation? Those patients having stable disease are right candidates for melanocyte transplantation. We define stability where there are no new white lesions or there is no increase in the size of previous lesions for minimum of 2 years. Some people take this as minimum of 1 year. Generally, we take opinion of dermatologists before going for melanocyte transplant surgery. There should not be cavernous phenomena where there is depigmentation at the site of trauma injury on the skin, or chances of keloid formation should be contraindication in some patients. Palms, soles, and acrofacial vitiligo are difficult to repigment. This we have to warn to the patient beforehand. Coming to the clinical cases done at Bembde Hospital using autologous non-cultured melanocyte transfer for vitiligo cases. Case number 1, this was a 21-year young male presented with non-segmental generalized vitiligo with white patches of varying size on the upper and lower extremities, as well as on the left side of abdominal wall skin. This was stable since last 2 years. So after patient has already tried topical steroids, phototherapy, and other conservative medical line of treatment, which were ineffective. Now patient, after discussion with various options, opted for autologous melanocyte transplant surgery at our hospital. This is the first stage of surgery. We do markings and measurement of total surface areas. Marking, generally we take around 2 millimeter normal skin surrounding the white patches. Second stage, we take 20 to 25% of total surface area of total vitiligo patches, this area of skin. That means if there is a 10 square centimeter vitiligo patch, we take generally 2 to 2.5 square centimeter epidermal graft. This should be very thin, transparent graft. Generally, we harvest it with dermatome. Then the third stage, we prepare the melanocyte suspension from these thin epidermal grafts. And once this is ready, we take the patient inside the operation theater and we do derm abrasion of all the marked vitiligo patches. After derm abrasion, we apply the suspension, which is already prepared suspension of melanocyte and keratinocyte, and we cover it with dry collagen sheets. And we do Bembde dressing on that. Generally, that dressing is kept for 7 days. This is the clinical result after 6 months of autologous melanocyte transplant. there is a natural repigmentation occurred in all the vitiligo patches over a period of 6 months. Again, this is the result after 6 months on upper extremity. This is the result on lower extremity, both lower extremity. There are some patches where there was hyperpigmentation. Again, this is the preoperative pictures, and this is the result after 6 months. When we assess it with vitiligo noticeable scale, the vitiligo was no longer noticeable as it was before the surgery. This is the vitiligo noticeable scale developed by University of Nottingham, where number 1 is more noticeable, number 2 is noticeable, number 3 is slightly less noticeable, number 4 is lot less noticeable, and number 5 is no longer noticeable. That is the excellent result. Another case, 26-year male coming from Bhubaneswar, Orissa for lip vitiligo, which is quite distressing to the patient as it is on the quite visible part. We marked the lip vitiligo area. We did dermabrasion and we applied the melanocyte suspension. And this is the result after 4 months of surgery. Another case, young lady having lower lip vitiligo. After dermabrasion, we put this melanocyte suspension, and we covered it with collagen dressing. And this is the result. You can see the repigmentation, how it looks after 4 weeks only, that is 26 days. And this is the result after 4 months. And this is the recent photograph which she has sent after 4 years of melanocyte transplant surgery. You can see very natural pigmentation of the lip. Another male around 25 years age, having both the lips having vitiligo patches. And we did dermabrasion and applied collagen suspension. You can see the excellent cosmetic result after just 4 months of surgery. This young man coming all the way from this Guwahati, that is Assam, having both the lip involved in vitiligo, including some part of mucosa was also involved. We did dermabrasion and applied melanocyte suspension with collagen, and this is the result within 6 months. And this is a late picture after 2 years, having excellent natural result. This is especially on lips is very satisfying to the patient. This young girl of 21 years age coming from Srinagar, Kashmir, she also had very good result, natural repigmentation after melanocyte transplant surgery. This is a young chap, 18 years old, having excellent cosmetic results after melanocyte only after 2 months. We have also given along with this UV therapy after 4 weeks. Again, this is a lower lip vitiligo, where after 4 months, you can see the natural repigmentation of the lip. This is a small clip where we have shown how we do the dermabrasion of lip, which is a little difficult for dermabrasion. We inject the vitiligo area with xylocaine solution so that it becomes little turgid and it will be easier for doing dermabrasion. This is another case where this lower lip vitiligo got natural pigmentation in just 4 months period. Again, this is a young male having lower lip vitiligo and excellent natural. You cannot make out whether patient had vitiligo patch beforehand. This is result after 4 months. Coming to vitiligo on face, this is on inner canthus, nose area, and some part of cheek. We have marked the area and we did melanocyte suspension, and this is the result. Excellent result. It is difficult to make out whether there were vitiligo patches beforehand. This result is seen within 4 months only. Then this is the example of eyelid white patches, leucoderma, and this is after complete treatment after 4 months of surgery. Again, natural result on the front neck part having vitiligo patches after the melanocyte transplant surgery after 4 months of surgery. This is a young lady coming from Dhaka, Bangladesh for lower leg vitiligo. Again, we did this dermabrasion and melanocyte suspension application, and this is the result after 9 months. She has sent the picture after 9 months of surgery. There is little hyperpigmentation at places, but she is very happy with the result. Such patients are more happy even if there is a little hyperpigmentation rather than having hyperpigmentation. Another young physiotherapist having vitiligo patches on lower leg, this on the dorsal aspect of foot, and this is the result after 7 months of surgery. This is the only case which we did for post-burn hypopigmented scar. Generally, we do a skin graft in such cases. In this case, we use melanocyte suspension, and she got satisfactory result. But we feel that it's not like other non-burn vitiligo patches. The result takes long time for pigmentation also. Coming to another option of split thickness epidermal skin grafting, which is a conventional method for treatment of vitiligo patches. We used to do these cases some 10 years back. Now, 99.99% we go for melanocyte transplant. This was a young male, 21 years male, was doing computer engineering, and he got non-segmental localized focal patches of vitiligo on his scalp, forehead, cheek, ear, and then post-auricular region. And he had tried all the medical line of treatment. And when he came to us, we discussed all the different surgical techniques, including melanocyte transplant. But patient opted for direct epidermal skin graft as he wanted to get the earliest pigmented result, and he wanted the 100% surety of the result. So in case of melanocyte transplant, we generally tell that 5% patients may need second surgery, or 5% area may need treatment after 6 months. But in case of skin graft, of course, the chances of repigmentation are on almost 100% area are more. So this patient opted for skin grafting. So we did dermabrasion same way, and then we applied a thin epidermal skin graft on all the dermabrated area, and this was the result after 20 days. You can see there were epidermal cysts beneath the graft. So we did treatment for that, and this was the result after 3 months. Not a very satisfactory result, but patient was happy. But still, we did follow for this patient. He also got UV therapy, and this was the result after, say, 9 months, and this was the result after 2 to 3 years. This was almost near normal pigmentation after 2 years. Again, this front view, there was cosmetic improvement in the grafted area after a period of 2 years. In the same patient, dermabrasion and skin grafting for very difficult and complex areas of external ear. Here again, we did the skin grafting, and fortunately, he got the natural result for repigmentation of vitiligo areas on this area also. Another case of dermabrasion with skin grafting. This is how we do dermabrasion. Then we put skin graft. This was after 20 days, and this when patient came 9 months after the surgery. It was satisfactory result, but there is little hyperpigmentation and some textural differences. This was a lady having vitiligo on upper eyelid, where we did dermabrasion and skin grafting some 15 years back, and fortunately she got the very natural repigmentation and good texture for the eyelid patches. These vitiligo, especially on lips, where we used to previously do skin grafting, has very poor result. You can see this is a patch-like look and very poor color and texture match. Now we don't do this surgery for lip. Even if patient insists, we go for melanocyte transplant for all the lip vitiligo cases. You have seen the best results in the initial presentation only. Again, one of the example of dermabrasion and skin grafting. You can see there is a poor color and texture match. This was a case we did some 20 years back. Again, there is a quite mismatch of texture and hyperpigmentation. And this was a dental student where we did this some 20 years back, skin grafting with hyperpigmented results. Again, this was a skin grafting and dermabrasion having satisfactory result. This patient again treated some 15 years back, dermabrasion, and we did grafting on this. But after a period of 3 years, when he visited to us, surprisingly, he had quite satisfactory result, though there were some areas of hyperpigmentation. This is another case where you can see the early results, textural and color mismatch. Coming to third method, that is complete excision of vitiligo patch and advancement flap. It is suitable only for selected small vitiligo patches on certain anatomical areas where there is a laxity of skin surrounding the vitiligo patch. It has satisfactory cosmetic results. This is one case where a young lady having this vitiligo patch on the west area. So there is a lot of elastic skin available. So we have done excision and advancement flap. Patient will have a linear scar. Another case on anterior aspect of neck. We have given her all the options, but she wanted total excision, and this was the result. We treated this scar later on. for minimal hypertrophy. So coming to the comparison and evaluation of various surgical treatment options for vitiligo, which we are using since last 23 years, melanocyte transplant, then skin grafting, and excision of the vitiligo patch and primary closure. What are the advantages of melanocyte transplant? It requires a smaller donor area to repigment bigger vitiligo patches. We use generally 20% of total surface area graft. Sometimes we can go up to 10 to 15% graft only if the vitiligo area is huge. There are better cosmetic outcomes with better matching of skin texture and color, which you have seen in the previous slides. What is the disadvantage of melanocyte transplant? The results take more time than skin grafting. Sometimes it may take 9 months also, but general results are within 6 months. It requires expertise, yes, of course, special training, knowledge of the technique and complex steps of melanocyte transplant. It requires specific sophisticated equipments and storage of chemical reagent at specific temperature. What are the advantages of direct split thickness skin grafting? It gives immediate resolution of vitiligo and reasonable cosmetic outcome over time. But of course, it is not as good as melanocyte transplant. What are the disadvantages of direct split thickness skin grafting? There is a possibility of mismatch of skin color and texture at recipient area in case of direct skin grafting. There is a possibility of graft rejection, or there can be displacement of the graft in dressing. There are chances of development of epidermal cyst, as I have shown in one of the case. It requires a larger surface area of donor site, unlike melanocyte transplant surgery. It may require 10% more than the total surface area of the vitiligo, because there is some contracture of the skin graft after harvesting. So coming to advantages and disadvantages of the third technique, that is excision and advancement flap. It gives best color and texture match, as the adjacent skin is used as advancement flap. So the best skin color match is adjacent skin, but it has very limited indications as per the body areas and as per the size of the vitiligo patch. It gives a linear scar, which is, you can say, one of the disadvantage. So coming to the conclusion, all techniques are effective surgical modalities for treatment of stable vitiligo as per the indication, especially for smaller areas. Almost all the techniques are fine in case of smaller areas. But for those who can undergo either techniques, the advantages and disadvantages must be communicated for informed decision making and ultimate patient preference. Our experiences at Bembde Hospital since last 24 years shows that melanocyte transplant is overall better technique with the best cosmetic outcomes, using very small area of donor skin, especially for large surface vitiligo cases and especially on lips. So this is our team, and I thank you all for the patient hearing. And